identity, stability. So identity, I'm a man, I'm a boy, I'm a girl. Stability, oh, boys grow into men, girls grow into women. Constancy, sex is who I am and it doesn't change. Now think about what's happening in our culture. What's happening in preschool? Well, in preschool, you're getting shown picture books by your school teacher, such as Introducing Teddy. Teddy is a teddy bear who's got a bow tie, and he's very unhappy. And he tells his little boy owner, I am so unhappy, I am so depressed. And he goes along, and lo and behold, Teddy is actually female. And once he realizes he can take his bow tie and put it in his hair, he's really a girl teddy bear, and now he's happy. And the little boy says, that's okay. You know, it's not what's on the outside that matters, it's what's on the inside. I love you just as you are. So think about the developmental level of preschool kids, age 3, or any child under age 7, and the gaslighting. Okay, gaslighting, that means destroying the reality testing that's going on in preschool. And then it's even worse when you go to your drag queen story hours and you have drag queens reading those kinds of stories to the kids. I Am Jazz, another very popular book by the transgender activists. And what's incredibly sad is that this boy was essentially, he's been impersonating a girl since the age of 5 with the full cooperation of his family and physicians and therapists. And he has become the transgender child rock star, basically. And he's got his own reality show, and it's actually very sad and difficult to watch. He's now about 18. In any case, in this book, which is designed for elementary school kids, Jazz, it's about his life as a girl. Well, I'm a boy. I'm a girl. You know, yeah, I had a boy body, but I've got a girl brain. So there is nothing more anti-science than saying a girl brain can be trapped in a boy body. That is just physically, scientifically impossible. From a pure genetic standpoint, we now know that males and females, men and women, differ at least by 6,500 shared genes. And this is what's fascinating. You know, we used to think, oh, all the differences between men and women, you know, they're only located on the Y chromosome. No, men and women have at least 6,500 shared genes that are expressed differently in virtually every tissue of our bodies, including the brain. So a woman's brain is hardcore, the hardware of a woman's brain, genetically speaking, is different, even though we share the same genes. Moreover, during prenatal development, when you get to about 8 weeks gestation, that's when your male fetuses, your male unborn children at 8 weeks, have testicles that begin secreting testosterone. So their brains are further masculinized. So they're masculine first by genetics, and then second by this extra endogenous testosterone that girls don't have. So pure science fiction and an outright lie to say, to teach children, oh, you could have a girl brain and a boy body and vice versa. So transgender medicine really is Gnosticism dressed up in scientific jargon, okay? It is anti-science, anti-real, and it's scary because we now have leading physicians who are saying things like, gender identity determines sex. Dr. Deanna Adkins, the lead pediatrician of the Duke University Gender Clinic for Children, has actually submitted written testimony saying that self-declaration trumps chromosomes, genes, and reproductive anatomy, that it's inappropriate to use actual science to determine sex. We have one of the most famous psychologists, child psychologists, promoting this ideology, goes around the country teaching parents that, you know, if your child asks, how can I tell if someone's a boy or a girl? You need to tell your son or daughter, well, we need to ask them. You know, she tells parents, you could tell your child, some people say that boys have penises and girls have vaginas. This is what you should tell your 2- and 3-year-olds. But that's simply not the way it is. Some boys have vaginas and some girls have penises. You're a boy if your mind tells you you're a boy. You're a girl if your mind tells you you're a girl. Pure Gnosticism. And I'll share one more story because it's so unbelievable. I do think, you know, we can't judge people's hearts or motives. I really believe they are just so wedded to this false ideology that they think they're doing good, but it's pure insanity. Dr. Joanna Olson Kennedy is one of the leading pediatricians, LA Children's Hospital. She presented at a professional conference to fellow physicians and medical students and residents, and shared a case of an 8-year-old girl who was brought to Dr. Olson Kennedy by her mother. The 8-year-old girl was being bullied because she's essentially a tomboy. So the doctor said to her, well, so are you a boy or a girl? The 8-year-old looked at her body, looked back, a girl. The doctor said, oh, well, do you like Pop-Tarts? Yeah, I love Pop-Tarts. Well, if I gave you a Pop-Tart that was in a strawberry wrapper and you took a bite and it tasted like blueberry, what kind of Pop-Tart is it really? Blueberry? And there was a pause, and then the little girl's eyes got big. She looked at her mother and said, Mommy, I think I'm a boy in a girl wrapper. And that child is now in the LA Children's Gender Clinic on puberty blockers set up for cross-sex hormones. And this doctor said to her audience, now, I didn't tell him he was a boy. I just gave him the words he didn't have. We have to give children the language to express what's going on in their minds. We are manufacturing deeply wounded children. That's the bottom line. And unfortunately, it is a tyranny from the top, because these physicians I've been talking about, they are in positions of power. They determine the standards of care. They determine what gets taught, and it filters down. It wasn't always this way. Not that long ago, prior to 2013, most physicians and therapists recognized that transgender belief was transgender belief, and that it was in the category of gender identity disorder, similar to anorexia, similar to body dysmorphic disorder. In fact, in 2006, a transgender psychiatrist named Dr. Ann Lawrence published an article in the Archives of Sexual Behavior saying that gender identity disorder is really similar to body integrity identity disorder. And this psychiatrist drew several parallels between transgender and what some call transable. So people, in other words, there are people who deeply believe they are disabled or amputees trapped in healthy bodies. And they are so emotionally distraught, they will seek out physicians to amputate limbs or to sever their spines so that they will actually be paralyzed or disabled. And this transgender psychiatrist himself said, look, you know what, there are all these similarities. We should really look at this for further study, research, treatment, etc. So what about these brain studies we hear about? Is there anything to that? There are a handful of brain studies over the last 10 years that purport to show differences between those who identify as transgender and those who do not. Well, how many of you got the memo about anorexic brains? Did you all see any big report splashed all over NBC, CBS, CNN about, ooh, anorexic children and teens have brain differences, born that way, can't be changed. What are we going to do? No. For decades, we have strong data showing brain differences between children, youth, and adults who have anorexia nervosa and bulimia nervosa as compared to those without eating disorders. But here's the difference. Politics, right? There's no movement for anorexic rights the way there's a movement for transgender rights. But scientifically, what's going on? Well, scientifically speaking, when physicians and researchers look at the data for the anorexic brains, we say, okay, there might be a predisposition, but the fact is, no one's brain is exactly the same today as it was when they were born, because the phenomenon of neuroplasticity. From the moment that baby first gazes into his or her mother's eyes, that gaze, relationship, starts rewiring the brain. So maternal-infant gaze, relationships, behavior, thinking, meditating, contemplative prayer, juggling, being a taxi cab driver in London, all these things alter the physical appearance of the brain and its functioning physiology. So what happens when we go to transgender? All of a sudden, when we go to transgender, oh, hey, these brain differences. Now, mind you, the studies are far lesser quality than the studies we have for anorexia, but no, all of a sudden, neuroplasticity doesn't exist. All of a sudden, we forget about that. The fact of the matter is, it is far more likely that transgender identified children and adults have been behaving and thinking and experiencing relationships that have altered their brain, potentially to enough to distinguish them from other members of their sex. Another area where politics has trumped medicine is twin studies. So isn't this in the genes? Everything about, we're made of DNA. So the fact that some sitting in the audience are nuns and priests, you know what? There's a biological predisposition to that. But predisposition is not destiny. It's not biological essentialism. Our skin color is determined by genes alone. So if you look at identical twins, because identical twins come from the same DNA at fertilization, if there is a trait determined by DNA alone, you'll find that trait in both identical twins virtually 100% of the time. Some traits are influenced by both genes and environment. For example, when will puberty kick in? There's a significant genetic and biological influence on puberty kicking in. And if you look at the timing of puberty, roughly 90% of the time, both identical twins will have puberty starting at the same time. There's still some environmental influence there, so it's less than 100%. When you look at transgenderism, both identical twins match for transgenderism only 28% of the time. That means 72% of the time they're different. So relatively speaking, because there's such a large percentage of difference, relatively speaking, that tells us that post-birth events contribute more to transgender identity than any biological predisposition. For anorexia, the likelihood that when both identical twins match is 44%. Transgenders, they match 28%. There is a greater genetic influence behind anorexia than there is behind transgenderism. But you would never know that from our culture. We're in a bind because mainstream medical and psychological organizations lie. They outright lie. WPATH, the World Professional Association for Transgender Health, publishes the standards of care. They're up to their 7th edition. On page 16, their standards of care say psychotherapy to align the mind with the body is always a failure and harmful, therefore unethical. They list 4 studies that allegedly prove psychotherapy to align the mind with the body is unethical. Thanks to our friends at Alliance Defending Freedom, they were able to obtain, the 4 studies were extremely difficult to obtain because they were all from the 1960s, well, except for one. Our friends at Alliance Defending Freedom obtained the studies. 2 of the studies have nothing to do with transgenderism. One of the studies has to do with, it's just a description of 100 transsexuals, has nothing to do with therapy, no mention of therapy. And the last one from the Dutch rather, it's a Dutch study from 1984, actually documents people who benefited from psychotherapy. So they literally lie. A last example of a lying organization, the American Academy of Pediatrics. This past October released their policy statement on transgender, gender nonconforming children and adolescents. They came out saying, regardless of a child's age, you must affirm whatever that child believes. Essentially, transition them socially and then on puberty blockers, etc., all of them. Fortunately, for us who are interested in the truth, Dr. James Cantor, who is a psychologist and a sexologist, he is openly homosexual, he is not conservative, he works in Toronto, he worked in the gender identity clinic there for many years, was rather intrigued by that statement, so he decided to fact check it. He pulled every reference that the American Academy of Pediatrics cited, and he wrote it up on his blog, sexologytoday.org. You can look it up, sexologytoday.org. Not one reference in the AAP's policy statement backs what they say. He said, as a matter of fact, every reference they cite backs what they don't. Every reference they cite says that standard of care is to be cautious and to watchfully wait at least to age 12. Moreover, he said, the AAP's policy completely ignored the fact that the vast majority of children will outgrow this by the time they pass through natural puberty. So if we block puberty with drugs in these children, we are denying these children the developmental phase during which most change their minds. What can parents do? What can parents do? Obviously, you need to get educated, and you're here, you're at conferences like this. I think an ounce of prevention is worth a pound of cure. If you have young children, you obviously need to protect them from the lies. And more, I am recommending homeschooling. I'm a mother of 4, my kids are older now. You know, at the time they were younger, I was able to be very much involved in the schools. We had a good Catholic school. You could be there. Even Catholic Christian private schools are not, you can't bank on that. If you have a child, a young child who starts to express that, you know, they're not their biological sex, first have confidence that this could just be a phase, and affirm your child as the son or daughter they really are, and hone in on their character as well. And what do you know, what do they like? What do they dislike? They don't have to conform to sex stereotypes, okay? So a girl, you know, if your daughter is a tomboy and she's picking up the messages from our culture, because it's everywhere, that this must mean she's trapped in the wrong body, you have confidence and try and bring her back to reality, affirm her as she really is. If you cannot do that on your own, then you do need to try and look for a therapist. And, you know, especially young children, parents and families do have power. And there are family dynamics that can be very subtle going on that you may not be aware of. And so I always recommend family therapy in this situation. It's not the child who has a problem, it's a family system that needs some fine-tuning. Now, yes, in some cases there's obvious abuse. We'll hear later from Walter Heyer, and in some cases this is triggered by sexual abuse, physical abuse. Sometimes we have women, mothers who suffer gender mourning, and they are so depressed because let's say they desperately wanted a daughter and they only have sons. They may actually subconsciously feminize the last son. But if you've seen our videos of the last panel, I discussed my patient, Andy. Andy, at age 3, started cross-sex playing mostly with girl toys, etc. By age 5, he was consistently and persistently insisting that he was a girl. In family therapy, it came out that at age 3, when his little sister with special needs was born, she suddenly took up all of the parents' time and energy. These parents weren't bad parents. It's subconsciously this child psychologically was misinterpreting, I'm not loved as a boy. So it can be very subtle. So how do you find good therapists? You can Google Christian therapists, and you will come up with a website that will allow you to find Christian therapists in your area. Again, that's not perfect, but at least it's a start. And then you need to interview them over the phone and literally ask, I would like to know, how would you treat a child who's confused about their gender? And the therapist has to tell you. You can do the same thing. You can, CatholicTherapists.org is another one where you can go to that website, input your zip code, and come up with options. Definitely stay away from gender clinics. Stay away from anyone who says they're a gender expert. If you're dealing particularly with preteen girls, body image, there's a lot of overlap with eating disorders and body image issues. You may have luck seeking out therapists who deal with body dysmorphia, body image. Interview them over the phone. You can also reach out to ACPEDS, that's acpeds.org. I do have a list of therapists who, again, they have to stay sort of underground, but they've agreed that I may share their names and contact information. They will provide therapy by Skype. And I also want to mention, because I have seen this not just in terms of gender dysphoria, but virtually whenever, and this isn't blame, I mean, I'm a parent too, but in any mental disorder impacting a young child or a teen, as parents, we need to take self-inventory, psychologically and spiritually. And I've met a number of really good parents who have some of their own psychological issues in the background. And real good Christians, Catholics, and I don't know what it is, I'm in spiritual direction, I'm saying my rosaries, I'm going to Mass, I'm in Bible study, I've got a great support group. I'm not minimizing that, but that's spiritual. Example, in one family, in this case, struggling with same-sex attraction in more than one son, the mother has a history of sexual abuse as a child that has never been dealt with in therapy. And though I can see, and the husband grew up in an alcoholic family. So whereas I can see the dynamic that's going on, I can see how she's not intentionally emasculating the males in that family, but that's what's happening. So, and she has only recently agreed when I gently suggested that, yes, she is going to go into therapy to deal with her past wounds. So I think it's really important as, I mean, parents in general, you know, therapy and spiritual healing begins with parents. What happens to our kids, you know, we have to make sure our ducks are in a row as well.
I have the perspective that I can share with you my work as a pediatric endocrinologist and specifically as a physician scientist. And I'm privileged to be able to work at a very well-respected institute that prides itself on developing scientific evidence, evidence-based medicine to be able to provide better care for our patients. As a disclaimer, I need to tell you that I am not representing that institution as I speak to you today, because it's an inconvenient truth about what I have to share. Before I get into the specifics of the science and give you some information on this, to be able to address some of the things that you're hearing, I'm sure, undoubtedly, in the discussion, we do need to acknowledge that the people that have gender dysphoria are truly suffering. They have a very high rate of anxiety, depression, substance abuse, eating disorders. It goes down the list. These are truly suffering individuals, and they're crying for help. The question that we need to ask is what is being offered to them to alleviate that suffering? Is that truly what is best for them? Is that going to lead them to the true healing that they seek? So in order to understand what is currently being put forward as dogma, as far as we've figured out how to address this particular problem and we know how to treat it, we have to critically examine the arguments that are being made. It's amazing to me that if we look at the evolution of the current treatment approach to gender dysphoria, how it has drastically transformed. Prior to the last couple of decades, we had always acknowledged people that had this confusion about their sexuality, and they defined it as gender identity as we move forward on this, that the problem stemmed from something related to thinking. And it was, people went far enough to say that this was an objective psychological disorder, and that the approach to treatment would be to address what is leading to that disordered thinking. In a very short time, over the last 20 years, there's been a dramatic transformation in that treatment approach. And rather than addressing what's going on in the mind, the assumption is that the problem is with the body, turning it completely on its head. And that's why I'm even here. I'm a pediatric endocrinologist. I deal with hormones. At the start, prior to the interventions that are now being proposed for treatment, this is not an endocrine disorder. It is not an endocrine condition. In fact, the vast majority, or nearly all of the individuals that are presenting for care to gender clinics have completely normally formed external and internal genitalia. They have normal reproductive function prior to the intervention of the doctors that are addressing this particular problem through the transformation or the attempted transformation of the body. And that's where I come into looking at this and being able to ask the question objectively, what is being put forward as care? You know, what is the evidence behind this, and is there a better way? Okay, and so that's what I want to talk to you about here. And it's particularly difficult not only for all of you in the audience that are not physicians, but it's even difficult for me as a physician and a physician scientist in my medical profession to ask questions about the scientific evidence. What we know now is that we heard about the WPATH, the World Professional Alliance for Transgender Health, that puts forward what they call standards of care. And really that's a misnomer, because they've made it into a standard. And again, to emphasize how these recommendations were made and understand what clinical practice guidelines are and where the limitations are and how dependent they are upon the evidence that's being presented to put those forward. You must know that these guidelines by all of the professional organizations are not put forward by the entire membership of the professional societies. Rather, they're being put forward by a very, very small subset of people that have a special interest in this particular condition. And I would go to say, as far as to say, an ideology that they want to put forward. And the reason I say that is that if we look back at what's being done in this area and what's put forward very dogmatically, in light of the evidence that's available, it is very disproportionate than what I've observed in my career in any other condition. To make a transformation as drastic as they made in addressing the body rather than the mind and making this changed assertion about the disorder being in the body, one would expect that there was a landmark study that had been done or a series of very carefully controlled studies that provided evidence that this was the best approach to make. And what you will find if you dig into the literature is that does not exist. In fact, when we look at the clinical practice guidelines, I'm an endocrinologist, and the one that I'm most familiar with are the Endocrine Society guidelines that first came out in 2009. They were revised in 2017. And in clinical practice guidelines, they provide an assessment of the quality of evidence that's being used to put those recommendations forward. Many people are shocked to find out there were over 20 recommendations that were made in that document. All but 2 of them were related on low or very low quality evidence. They rated on a scale from very good evidence to moderate evidence to low evidence. By definition, that designation of low or very low quality of evidence means that there's a very high likelihood that as new information becomes available, that there will be a need to revise those clinical practice guidelines. In fact, there's ample examples throughout the history of medicine where things that were put forward as what we should do as standard of care that were found to be completely false. So to ask the question, and as a physician scientist, I constantly do this, is look at the evidence and try to assess as we get more evidence what is going on. We need to be critical about what we are being presented with. And I know we have a diverse audience here this morning, and not everybody gets to live in the world that I do as a scientist and as a physician. But let's walk through just very briefly some of the limitations of the medical studies that have been published that are being used to support this. And this is even beyond the outright inconsistencies and the incorrect citations of literature that don't even address the issue that Michelle talked about. First off, there's a very few in number of the studies that have been published in this particular area. Now that's rapidly changing because now this is an area of focus and people are now our government is willing to fund more and more studies. And we'll talk a little bit about the studies that are currently going on. And if I have time, I'd like to propose to you some of the studies that really need to be done and we need to really advocate very strongly for. So they're very few in number. Most of the studies are what we call retrospective. They look at things in the past. They don't look at an intervention moving forward. Many of them rely on convenience samples so that they recruit patients for the study, for example, through internet questionnaires, which has an inherent bias in the people that are going to sign up for these studies that have a preconceived desire for a specific outcome. There are also very small sample sizes, and again, prior to the trend now of the exponential growth in the number of people that are presenting, this was a very rare condition. So it's understandable why some of these studies were done with very small patient sample sizes. But as we heard in the previous talk, that there are many components to what causes somebody to identify as being transgendered. And I would say the best way to summarize that data is that it's a multifactorial process, meaning that there are a number of different factors that contribute to the expression of that transgendered identity. There is there's evidence for a biological predisposition, not determination as we heard. There is an environmental influence that can be either hormonal exposure or things within the environment. But if you're going to make clinical practice guidelines or standards of care based upon studies of maybe a dozen patients where the patients within that study said by themselves may differ in the causes that are present in causing this, there's a high potential for reaching erroneous conclusion. Another problem, and probably a major problem, not all of the studies are uncontrolled or poorly controlled at best. And in science, when we try to get truth, we need to make sure that we separate out association from causation, that we can distinguish the effect of a clinical study from the intervention and not another factor. And there is so much opportunity for that to lead to false conclusions. If you look through the literature, especially these studies are very short-term in follow-up, not looking at the long-term outcomes. And certainly Dr. Josephson can talk more about the effects of this intervention of affirming somebody in their gender identity and the alleviation temporarily of their discomfort. But what we really need to understand is what happens long-term. And the few studies that are done in long-term effects have a tremendously high rate of dropout, meaning patients that are lost to follow-up. And we must ask the question, what happened to them? Did they find out that what was being offered to them did not help, and they were decided they didn't want to participate anymore in that research? Did they themselves commit suicide as a result of this? We really need to understand this. So in science, and I teach a course on ethics at my university, we teach the scientists in training to be aware of bias. It happens everywhere. We have to acknowledge our biases, and we need to address that up front and be able to try to, as best we can, to move ourselves away from this. And when we look at the studies that are being done in this particular area, there is so much potential and many areas where we can definitively establish that there was bias that was present in the studies that were done. How does this play out? Well, so in order to be able to do a study, you need money. In order to get money, we usually apply to organizations like the National Institute of Health. There's a very small subset of people that review grants. And when the people on the study section have a particular interest because they're identified as the specialists in the field, and they exclude people that raise questions about what's going on, it heavily influences the studies that get approved for funding. It also happens at the end of the study when things are going for publication. They undergo a peer review process. And if you have a reviewer that is themselves biased in this, there is certainly an opportunity for there to be a swaying of what actually gets published. Another problem is that even when you read the studies that have been published, because of the biases and the conclusions that are reached by the authors of that study, many of my colleagues, I challenge them frequently to not read the title and the abstract of a paper and then consider it fact. Because if you dig deeper into the paper itself and look at the methodology, very often there are serious flaws that are present in the research that was being done. Sometimes it's acknowledged. If it's done well, the authors will acknowledge the limitations of the study. But not every case is that done. And then the conclusion that is reached is not necessarily supported by the data. So that there really is a need to have skepticism about the literature that's being published right now, and certainly the information that's being used to tell not only the practitioners that are being called to join these gender centers to participate in the care, but also to the parents for children that are presenting and adults that are presenting themselves for this care. They're coming to people that they're viewing as experts, and they need to be critical. And I would say that you need to do this in all areas of medicine, but this is something particularly that you need to be aware of when we're dealing with the area of transgender medicine. So with that just a broad overview, and there's much more that I could say about those scientific studies in the limitations that are present within them, in the few minutes I have remaining, I'd like to just go through some of the components of the care that's being offered to these individuals and point out some of the very obvious difficulties that one can have in what is being put forward. Very briefly, so in the way that we're talking, the very first intervention is really not even a medical intervention. It's called social affirmation. This is where one affirms rather than challenges somebody that presents with a transgendered identity. Now, this is very unique, this area of transgender medicine, because it is not restricted to the doctor-patient relationship. It is not even restricted to the investigator study subject. What is being done is really social experimentation, because we're recruiting the entire society to buy into this and being mandated to participate in what we don't really have any evidence for as far as long-term benefit. There has never been a controlled prospective study with social affirmation to say that this is the reason why children are feeling better. It's a hypothesis, It may be a good hypothesis. It's certainly worthy of study, but that study has not been done. And so in getting consent for research, teachers at schools and parents and people that live within the communities of these individuals are not being asked if they want to participate in this research. They're not even being told it's research. They're being mandated to comply with that. Now that's before we even get to the medical interventions. In addressing the issue of pubertal blockade in the area of pediatrics, somebody that has a discomfort with this discrepancy between their gender identity and their sex is when they're developing normally, and that we're talking about normal pubertal development, the change from childhood to adulthood, to intervene at a stage to suppress that from happening. And the arguments that are made to support that are that it's safe and effective, it's readily reversible, it gives somebody time to be able to sort things out, and then lastly, it provides a better outcome if they decide to go on to have surgery because you don't have to correct the changes of the body that were undesired. Each and every one of those assertions is filled with half-truths, untruths, or outright lies. Let me talk a little bit about the developmental aspects of this. To say that it's safe and reversible. Reversibility. We're interfering with a normal developmental process. By reversible, what they mean is that when you stop the medicines, the signals in the brain that trigger puberty will resume. That part is true. Okay? But you've interrupted a developmental process and you don't have any opportunity to go back in time and recapture the time that was lost. Adolescence is, and again, Dr. Josephson can speak more than I can about this, is a critical time of anyone's development. It's actually critical, and when you're interrupting that, you cannot say that it's reversible. Safe and effective. These are drugs that have never been studied and approved by the Food and Drug Administration for use in suppressing normally timed puberty. They've been used for other indications, suppressing early puberty or in treating cancers and other indications. So to make that claim is false because we don't have evidence to actually support that. Cross-sex hormones. Well, actually, before I get into that, saying that the children will have more time to sort out what is going on. The evidence that was already presented, the vast majority of children that present with gender dysphoria will outgrow the condition. They'll realign their gender identity with their sex, even if they're just left alone or supported. The few studies that are available, the one key study that was available in looking at this question of pubertal blockade shows that all of the patients that underwent pubertal blockade went forward with cross-sex hormones as well. So we've potentially, as a hypothesis, can ask the question, did this change the normal trajectory? And were you driving people more into a lifelong commitment to medical therapy, dependency on the medical profession, and with the harms that are associated with that? And even making the argument that the outcome of desistance is a good thing is fought with protest by people that are driving this ideology. Why would it not be a good outcome that somebody would realign their gender identity with their sex and not need cross-sex hormones for life and undergo all these other procedures that are going to put them at tremendous medical risk? So we need to question that. Cross-sex hormones, again, there are many problems with or potential harms that are induced by cross-sex hormones. We've already talked a little bit about the genetics of the programming of the body as male and female, and we heard last night the requirement by the NIH to do studies in males and females, recognizing the biological differences between responses to medicines. So to say to give estrogen to a biological male is the same thing as giving it to a female is objectively false. There is programming at the genetic level in every tissue of the body where the body responds differently to these hormones. And the level of hormones that we're exposing people to are not native physiologically and can cause significant harms. And just to list a few of them, increased risk of stroke, cardiovascular disease, diabetes, and most concerning is the potential of infertility, sterilizing children. Certainly with pubertal blockade followed with cross-sex hormones, the expected effect is to lead to sterility. And that is actually, even by the people that are advocating this treatment, will actually counsel parents and children on this effect. Now, children don't understand the implications of that, and so they tend to dismiss it, but it's certainly something that is very prevalent and needs to be addressed. So I won't say much about the surgical interventions, but I think we find throughout the scientific literature that there's very little evidence supporting this. There is concerning evidence that we're leading to serious risks. And then the question is, do we actually accomplish the desired effect? Because the prevention of suicide is driving most of these recommendations. The claim is that if you do not participate in this care, your child will die, okay, by suicide. But when we look at the scientific evidence, it doesn't support that assertion. There are very few studies that have looked at the long-term effects of this gender affirmation approach. There has been no studies long-term in children, and the few studies that have been done in adults show an alarming picture. The largest study was done in Sweden, where they saw at least 20 years after this intervention that the suicide rate was still 19-fold, completed suicides were 19-fold above the background population. It was not a controlled study. We can't say what the intervention itself did, but we can say with certainty that it didn't solve the problem. And I won't get into all of the discussions about social stress theory, the arguments that people make as to why it didn't work, but there is no science that convincingly demonstrates that this is what's going on. What is being put forward as a hypothesis has not been proven. So I think we need to step back and say, what can we do right now to do justice to these children that are suffering, and propose alternate hypotheses and design studies that are going to truly have benefit. Some of the largest studies that our government is spending right now to understand what's going on, one of the largest is a natural history longitudinal study to enroll patients to see what happens to them over time. To find out potentially 20 years from now we did tremendous harm to these individuals. They're merely collecting the data as they go forward with what they're putting forward as standard of care without really knowing what they're doing. And I've been with my colleagues and challenging them on what evidence do you have that this long term is effective, and they will admit readily, they have to, that there is no evidence. So this is something that we need to be aware of as we propose what needs to be done. So to ask hypotheses and alternative hypotheses, one of the things that we can do is begin with biological reality from a position of understanding the human person that any scientist would accept as far as what it means to be a man and a woman. Rather than beginning with an assumption based on ideology, begin with what we know from biological facts, and be able to propose these interventions that can be done in a truly compassionate, in a safe manner. Again, the justification for not doing the prospective controlled trials is often that it's unethical to have a control group. Well, I would say yes if your control group is to do nothing. But I don't think any scientist or physician is going to say that the control group should be doing nothing. In science, what we do is we control for all of the factors that are present in that patient, that studied population, with the exception of the variable that you're trying to study. You can provide equal care to both groups in a very controlled manner and be able to address questions and get answers to this very, very difficult problem. We really don't know what we're doing. We're claiming, the people that are advocating this claim that they know what they're doing, and they're now mandating that we can't even question from a scientific basis what is being going on. So the suppression of knowledge is an injustice not only in the area of transgender medicine, but applies to the entire practice of medicine and science that we're co-opting what we've long held to, and with very serious and potentially harmful consequences. So I really thank all of you for being here again. I would love to have more time to be able to share with you more details of that, but at least I hope that what I presented to you gives you the empowerment to at least question what you're being force-fed as far as what is going on as far as the medical treatment of these individuals, and to be able to question what is going on and be able to be aware when these things are being said, how to respond. Again, hopefully Dr. Josephson will address the issues of psychological care, because that really is the opportunity for true help, rather than invoking and enlisting endocrinologists like myself to be able to create a disorder that did not exist from the beginning. So again, thank you very much for your attention, and I look forward to the discussion afterwards.